Good morning, everybody. Good afternoon, good evening, wherever you are in this world. Welcome to this webinar, which is about post-COVID-19 challenges for patient care in low middle income countries. I hope I am audible. Welcome everybody from different parts of the world. This webinar is really looking at post-COVID. We've had a lot of advancement in treatment of COVID, different drugs that are used during COVID, but we realize that a lot of patients are coming up with complications after COVID. And this webinar really seeks to understand these complications and help us refocus some of our attention on how to manage our patients better and help them cope with the complications that come after COVID. We have a number of speakers today who will take us through, who have different expertise and will take us through their experiences with managing patients after COVID. The webinar is organized by COVID-19 Clinical Research Coalition's Clinical Epidemiology Working Group. So we're very pleased that they organize this conference, and we thank all the organizers. My name is Dr. Christine Sekaja Wiltshire, and I am an internal medicine specialist from Uganda. The focus of my work is really hematology, but I also conduct research in infectious diseases. I work at our national referral hospital called Mulago National Referral Hospital, and I also do my research in Infectious Diseases Institute, which is under Makerere University. So welcome you all. I'll introduce the various speakers as they come in, but for now, I'd like to give you an overview on today's agenda. So first on our agenda, we'll have our background. We'll have a first speaker who is Juan Carlos Villa, and he will give us a background into the post-COVID spectrum. And then we'll have a clinical case definition of post-COVID-19 condition, which will be by Juan Soriano. After this, we'll have a presentation from Agustin Chaponi, which he will talk about post-COVID-19 conditions in Argentina. Then we'll have Ms. Heather Stone, who will talk about the potential for repurposed drugs as treatment for long COVID. And lastly, we'll have post-COVID-19 conditions challenges for patient care in low middle income countries by Dr. Tanvir Ahmed. You will be given an opportunity to ask the speakers questions after the roundtable discussion. And we'll have closing remarks by Professor Richard Morde right after that. So right now we'll have some housekeeping rules. Today's webinar is being recorded, and a link to the recording will be published soon. Please feel free to ask questions using the Q&A tool, which is at the bottom of your screen. At the bottom of your screen, you can see there's a Q&A tool. Please use that to ask any questions. And if you'd like to address a question to any one particular speaker, please include their name so that they can know the question is addressed to them. And when you leave this event, please fill in a short survey, which will be sent to you. And we thank you in advance for agreeing to fill this short survey. So right now, I would like to introduce our first speaker. I'm happy to introduce Professor Juan Carlos Villa, who is a clinical epidemiologist with a background in preventive cardiology. He's currently the head of the research department at Foundation Cardio Infantil Instituto de Cardiology, a referral center for cardiovascular medicine in Bogota, Colombia. He's a professor in the Department of Medicine at Autónoma University in his hometown at UAM. That's the university, where he teaches evidence-based medicine and is a director of a master's program in research methods. He's one of the co-chairs of the Clinical Epidemiology Working Groups within the COVID-19 Clinical Research Coalition. So welcome, Professor Juan Carlos, and please go ahead with your presentation.
Thank you so much, Dr. Sakaya. And on behalf of the Clinical Epidemiology Working Group, welcome everyone who is participating, and especially the colleagues who are speaking today and helping us understanding the post-COVID condition. You may have seen this slide before, but as a reminder of what we do at the Clinical Research Coalition, we are a group of professionals seeking a global research response to COVID-19 that focus that is driven by the needs of low resource settings. We commit as members on promoting open sharing of research knowledge and data. We want to leverage global expertise for doing and translating high-impact COVID-19 research. We want to work for equitable and affordable access to COVID-19 vaccines, diagnostics, treatments. We are over 200 institutional members from 69 countries now, and we are split into different working groups. I'm co-chairing the group of clinical epidemiology. We have 13 groups, and we work together in trying to do different outputs. In the case of our clinical epidemiology group, we have met regularly over more than 6-9 months now, and we started by prioritizing research questions that we want to focus on. We are currently developing a protocol of a pilot study to try to collect individual data on different countries representing the so-called Global South. We have also worked in publications. We have just a letter to the editor accepted just in the topic that we are going to cover today. This is the membership in the middle of this slide. As you can see, we have colleagues from different parts of the world. We have been lucky to have Luz Angela Torres and Karen Moreno, my colleagues here in my institution, help us coordinating, and this is the link for those interested in joining the group or learning more about our work. On the reasons we thought of this webinar, we thought on how are we as people from lower and middle income countries prepared to care for the incoming patients with post-COVID condition. We want to ask ourselves, do we even know what post-COVID condition is? And what we can expect on this potential wave of patients and a public health concern that is incoming, that is still unknown in different aspects. We asked ourselves if we can even guess how we can treat, when these patients can be treated, who will be the team to treat these patients. Are we capable in terms of resources, capacity, etc., to care for these patients? And will this care be different in low and middle income countries as other parts in contrast to other parts of the world? So in terms of aims, we ultimately want to gain more understanding of this still unknown condition, and especially to raise awareness on the implications for low and middle income countries And that's why we have been lucky to have Professor Soriano, who led the WHO group in coining a definition that hopefully is portable, is practical, is operational for the and can connect different professionals in the world to work on that construct that we are now calling post-COVID condition. And we also have a headstone from the FDA Cure Group speaking on what are the hopes and the search for treatments for post-COVID conditions. And we also have two colleagues of our group to talk about the experiences in their countries to understand what can we expect, how big this burden can be, and what could we do in terms of preparing for this potential wave of post-COVID condition, especially for caring the patients. So this is the initial message, and we are more than pleased to have the speakers and welcome you again. And I'm giving this to you again, Dr. Sakaya.
Thank you very much, Professor Juan. So I'm introducing our speaker who will be giving us a clinical case definition of post-COVID-19 by Delphi consensus. That is Professor Juan Soriano, who works at the Department of Respiratory Medicine at the Hospital Princesa, and is an associate professor of medicine at UAM in Madrid. In May 2011, he received the Joseph Trueta Award for Scientific and Medical Achievements, and he serves as a consultant up to 2021, he served as a consultant in COVID-19 management at WHO in Geneva. Juan is active in COVID-19 related research and leading several research studies and clinical trials in long COVID. So please welcome Professor Soriano.
Thank you, Dr. Sakaya. Thank you, Christine. And also thanks to Professor Villar for inviting me to this Clinical Epidemiology Working Group webinar on this important topic. Before I start, I should tell you an apology because I'm in an airport and maybe there is some background noise. And also, if I can have the command on the slides, here it is. I will talk in the name of a big group of people. This was a publication in Lancet Infectious Diseases last December, and it was with a big group of staff from the WHO, some patients, and also some key researchers in the US, Canada, and other countries. So this presentation is a group one. Because I'm one of the first ones to speak, I wanted to give you a hint of where we are in terms of the pandemic. And this was the first publication in a scientific journal that mentioned the nightmare that we are suffering now. It was 2 years ago, the 17th of January 2020 in Science. And this journalist said from the Wuhan fish market in China had the nightmare returned. Even they were quoting a local researcher saying this is a limited outbreak. If no new patients appear in the next week, it might be over. Well, 2 years later, not only is not over, but is actually more larger than ever. And this is the official 5 waves from the WHO website, identifying that in each one of the waves that the world has been suffering, actually one continent has suffered more than the others. So this is a global disease. This is a pandemic. The numbers are huge. And now we have more than 450 million cases and almost 5.7 million deaths globally. If you go to PubMed, one of the repositories of medical information that we use the most, there are more than 220,000 papers on COVID-19. If you do the maths, that is that in the last 2 years, you were reading these papers, you should need to read more than 290 papers per day. That is one every 5 minutes. That's without weekends, and that's without sleeping. So webinars like these are very important to talk about COVID-19 or even about long COVID, that actually there are more than 700 papers on post-COVID condition, long COVID, sequela of COVID, post-acute sequela of COVID-19, or the related terms that we are using to refer to this new disease. The Director General of the WHO, Tedros Adhanom Ghebreyesus, was saying in Nature last October that the WHO is listening to patients, and actually that the WHO received the SOS, and actually we were in together, so the only way to be out is by including patients in all the WHO initiatives, especially because we have to fight negationists in all avenues. And this was a letter in a high impact journal, JAMA Internal Medicine, when some researchers were even questioning, is long COVID real? And again, inside and outside, we still have to defend that not only this exists, but the burden is huge at the population and at the individual level. For instance, in the WHO headquarters, already since February 2020, there were ICD-10 and ICD-11 codes to refer to the different COVID-19 diseases that we were identifying. And from July 2020, there was also a ICD-10 and 11 code, U09.9, referring to post-COVID-19 condition or long COVID. I was hunted by the WHO initially in October 2020 to model the synergy of influenza with COVID-19. Thank God there was no influenza with COVID-19 synergy at that time, so they gave me two tasks. One was to update the clinical guidelines for COVID-19, and the second one was to have some order in this new disease, long COVID, sequela, and others. So one of the first things that we had to do is to have an agreement with the name and especially with the definition. And definitions we could quote like Shakespeare. Shakespeare was saying with a rose, what's in a name? That which we call a rose, but by any other name, it would smell as sweet. Well, some people say that asthma is like love. Everyone knows what it is, but one cannot agree on its definition in an individual patient. The methods that we use in the 80s to define new diseases like AIDS or fibromyalgia, or even 2 years ago to define the post-intensive care unit syndrome, were used also to define post-COVID-19 condition or long COVID. And these methods are called Delphi. Delphi is an actual real city in Greece, and we are not meeting in Delphi. We are using Delphi's method. And the Delphi method was something that is a standard way to conduct research and to achieve consensus when there is limited information on a new disease. So we were using this platform. This was the Delphi Manager platform at the University of Liverpool, and we engaged more than 700 patients, carers of these patients, and also clinical experts in basic science and in clinical science both in WHO and in academia, especially when you are doing some consensus, you have to agree with the statistical rules. In this case, in a Likert scale from 1 to 9, consensus was identified in those that were receiving agreement from 1 to 3, or disagreement was when there were agreement in these 7, 8, or 9 scores. In all other combinations, there was disagreement. I don't want to overwhelm you with data. You can go actually to the publication and see the results by yourself. It is open and free of charge for viewing from PubMed. But what you can see in this slide is that there was a huge representation from the world, that the representation of by gender in male and female, or even non-binary, was included. The age distribution included the very young and the very elderly. And as I said, the global distribution was in all continents, perhaps with some decrease in terms of Africa. These were the domains and the symptoms that were asked to the panel of participants, and the history of probable or definitive infection with SARS-CoV-2 infection, symptoms present 3 months after the infection, the symptoms lasting for at least 2 months, and very importantly, that the post-COVID-19 condition, long COVID, and cannot be explained by an alternative definition or diagnosis. This is the actual definition. I will not bore you by reading all these 96 words and 8 lines, but I think that this is a beginning. This is something that perhaps with big data from primary care in unbiased samples, we will be able to identify the thresholds, the specific symptoms, and the timings, both in initiation, stopping, and duration. I'm just finishing, but I just give you 2 more slides. One is that there are huge opportunities for research, not only on the mechanisms. Now we have 7 mechanisms available to consider and actually to produce new treatments, but also the importance is on the natural history of this syndrome, on the risk factors and the protective factors for patients, and also on the timing of this distribution. And of course, especially because we are doing this webinar specific for low and middle income countries, the impact of this post-COVID-19 condition in countries like Bangladesh, India, in the Americas, or in other parts of Africa and Asia will be something that we will look at. So I just finished by some general concluding remarks, saying that a definition and a name is a first step in the right direction to establish a dialogue among specialists and specialties, that there is an urgent need to quantify thresholds and timings for this new disease, and especially the results will come from big data in primary care unbiased samples. And finally, that any management decisions and any recommendations that we come up, they have to be adapted to low and middle income countries. Thank you.
Thank you so much, Professor Soriano. Very interesting talk. Our next speaker is going to present his experience in Argentina. Dr. Agustin Chaponi is a family physician and researcher. He's a faculty physician of the Community and Family Medicine Service at the hospital in Italiano de Buenos Aires. And he's the Cochrane Argentina Director and Principal Investigator of CONICET. He carries on teaching activities as assistant professor at the School of Public Health in Buenos Aires in Argentina. Very welcome to you, Dr. Chaponi.
Thank you very much. First of all, I declare to have no conflict of interest, and I want to give a picture, a big picture of the burden of disease of COVID-19 pandemic in Argentina. We can see that the number of cases is around 10 million during all the pandemics, and the number of death is reached nearly 120,000 deaths. The number of cases is also the same at January 23, and the number of deaths it's around 100 a day. This is dynamic, and in the last 20 days it changed a lot. The number of cases dropped to 20,000, but the number of deaths increases to 200 a day. What about the vaccination? That is a very interesting component of this condition. The 86%, at the moment 88% of the whole population of Argentina received one dose of COVID vaccines. 78 at this moment received 2 doses, and 1/3 at this moment received 3 doses. If we see Argentina in the context of Latin America and the Caribbean, in the number of cases, this is the range, the minimum and maximum range in Latin America and the Caribbean, and we are here 7.7 million, and we are heading in number of deaths in the range minimum and maximum from the region. And this is what happened if we compare with the globally with worldwide. We are more close to the lower limit than the upper limit. Sorry, I want to go to the next. Okay. What about the management of long COVID in Argentina? The Ministry of Health developed recommendations, but only for pediatric populations. That is the only formal recommendations. The Argentine Society of Medicine provided practical recommendations for adult patient care with long COVID, and there is also a consensus of Argentine respiratory medicine societies that provide recommendations on pneumological monitoring of long COVID-19. And about the care, what about the care of long COVID patients? A few hospital services have independently organized post-COVID-19 clinics, but most of patients in Argentina with persistent symptoms are managed by primary care providers. I only found one formal research in Argentina, that is a cross-sectional study about long COVID that included 85 patients with confirmed COVID-19 who attend to an outpatient basis after the acute phase. In this case, the definition used was more than 3 weeks, not as Soriano showed in the consensus. And most, 86%, had mild disease, 45 were women, and the mean age is 43. After the acute phase, around half present persistent symptoms like fatigue, COG, insomnia, COG 33%, insomnia 19%, and anxiety 16%. Female sex, obesity, age between 35 and 55 years old, and initial hospitalization were associated with persistence of symptoms. This study observed that symptoms usually resolve over time. If you ask me, as Juan Carlos Villar asked the reason of this webinar, are we prepared for a large burden of COVID-19 in Argentina? I need to say that we are not completely prepared. So we won a grant of the Ministry of Health and we are preparing a multi-center descriptive study in Buenos Aires city and the province of Buenos Aires to determine the mortality, clinical sequela, and quality of life in patients discharged from intensive care unit with diagnosis of COVID-19. So we think that we will have some insights about long COVID. Just to finish, I want to share with you a reflection, because COVID-19 vaccination and the Omicron variants are game changers. So I ask if we should rename COVID-19 by COVID-21, for example, for the name of the disease that Omicron variant produces. And also the vaccination is a game changer. So maybe the long COVID with these two factors should be different that we are estimating at this moment. Well, thank you. This is my organization.
Thank you, Dr. Ciapponi. We'll move on to our next speaker, who is Ms. Heather Stone. Ms. Heather Stone is a health science policy analyst at the US FDA in the Clinical Methodologies Group of the Office of Medical Policy, Center for Drug Evaluation and Research. She joined the FDA upon completing her master's in public health from University of Maryland in 2012. And her research is focused on the creation of policies that will encourage drug development for infectious diseases. She applies her policy expertise to issues related to drug repurposing, clinical trials design, and antimicrobial drug resistance. So very good, big welcome to you, Ms. Heather Stone.
Thank you so much. So today I'll speak with you about the potential of repurposed drugs as treatments for long COVID. As all of you know, the information that we have about understanding the pathophysiology of long COVID or post-acute sequelae of COVID or post-COVID condition, depending upon how you want to refer to it, is very much still evolving. And there's a great deal of knowledge left to be gained. However, in recent months, we have begun to see some initial data suggesting some of the routes by which the disease causes injury in acute COVID and the consequences for patients who continue to have symptoms many months after their initial infection. So a couple of publications have recently pointed to at least 6 contributing factors in the acute COVID phase. So nutritional depletion, gut dysbiosis, organ injury and fibrosis, viral persistence, autoimmunity, and viral reactivation, which leads to ideas about cellular activation and dysfunction, including of histamines, cytokines, and coagulation pathway proteins, as well as the roles of fibroblasts, neurons, platelets, endothelium, mast cells, macrophages, and neutrophils. These lead to long haul symptoms of many kinds, of which were presented, some of which were presented by previous speakers, but 3 of interesting groupings of these symptoms are in the dysautonomia and POTS sort of presentation, coagulation issues, and then mast cell activation syndrome type responses. And so as a result, these symptoms suggest the possibility of different therapeutic strategies, of which I've highlighted just a few based upon classes of drug treatments, which could be considered based on the hypothesized pathophysiology that initial data has been shown to support. So these include things like beta blockers and benzodiazepine for patients with the dysautonomia presentation, anticoagulants and IL-6 blockers for those with coagulation disorders, and H1/H2 receptor antagonists or leukotriene inhibitors for those with mast cell activation syndrome presentations. In general, I think it's important to focus our sights on the opportunity that is presented by repurposed drugs, as well as the challenges of studying them. And this is true really globally, but has even greater importance in low and middle income countries, given the limitations that frequently occur with access to medications, including their availability and high cost. So it will be important to specifically focus on the potential for repurposed drugs to serve as treatments for long COVID, and not solely to emphasize development of new molecular entities. This is not to suggest that development of new drugs is not crucial. It absolutely is. But as we all know, that is a very long-term endeavor. And it's, I think, unfair to ask patients to wait 10 or 15 years for a new drug to be developed when there are reasonable possible solutions that are available on the pharmacy shelf today. And then the question becomes, how do we identify and prioritize those drugs? And how do we ensure that they're studied in a scientifically robust way so that we can actually generate evidence of whether they are in fact effective or not effective? So particular attention, I would argue, should be paid to drugs that are off patent or generic, are low cost, readily available in most countries, have a well-established safety profile and relatively low risk, do not have major drug-drug interactions, particularly with other commonly used medications, and have easy administration, for example, oral routes and not very frequent daily administration. So these are the considerations, and I would just encourage all of us to think about ways in which we can study these drugs in appropriate, controlled, preferably randomized clinical trials, as well as collect real-world data on how they're being used off-label, which could be used to inform those trials, and encourage all who are interested to become involved with the Cure Drug Repurposing Collaboratory's work in this space. Thank you so much.
Thank you very much for that very interesting talk, Ms. Heather. We have our last round table discussion speaker, who is Dr. Tanvir Ahmed, who holds a master's in public health and a PhD from University of Sussex. And he has worked for more than 13 years in LMIC with a primary interest in understanding disparity across public health issues. He's good at mixed method research and has applied a wide range of tools in digital health, public health nutrition, HIV, COVID-19, maternal and child health. So we welcome you, Dr. Tanvir.
Thank you very much, Dr. Sakaya, and I'm very honored to be here. I hope I'm audible. I'll be basically talking about a picture of LMIC around post-COVID conditions and my experience from Bangladesh mostly. So in Bangladesh, and I believe most part of the low and middle countries, we don't know much about specific patterns and clusters of symptoms on long COVID or long-term impact of COVID-19. There's only few studies which have talked about some symptoms which are hypothesized to be related to the, can be considered as the post-COVID complications. So our observation mainly from Bangladesh suggests that there are a considerable number of proportion who had previous COVID-19 infection suffers from physical as well as mental issues, which includes their family members as well, and the community at large affects them. And so from that context, we think not only it is important to understand post-COVID complication through a clinical lens, but it is also important to understand both the system issues around it and the contextual challenges. So as I already mentioned, that there are not much studies are going on to understand post-COVID complications in Bangladesh. To the best of my knowledge, there are 2 different studies which are primarily biochemical and clinical, are trying to understand various signs and symptoms related to post-COVID conditions. So at Sajida Foundation, which is a development organization based in Bangladesh, working for quite a long time, we are trying to look, for lack of a better word, I'll say, more offer a 360-degree angle to understand or approach post-COVID conditions. In that sense, we're trying to understand context of people who had COVID-19 infection or related symptoms, and they're in the later part, when they in their remission or when they were discharged from the hospital, various physical and mental health related signs and symptoms, and how these post-COVID conditions are related to individual patients' socioeconomic status as well as related changes. So from that angle, we are basically right now in the middle of these 5 studies. 1, 2, 3 are mostly focused on understanding the context from frontline health workers who worked with the amidst COVID pandemic, with the community, and how they're adapting to all these challenges, especially family members of COVID-19, of patients who suffered from COVID-19, and case study of Sajida Foundation, who actually rendered services for the pandemic, to understand the way an organization should respond to challenges. And then specifically study 4, which is to investigate physical and mental health burdens among people who are admitted in a hospital with COVID-19-like symptoms and their relationship to corresponding socioeconomic factors and related changes. And number 5, which is not yet in the field, we've just submitted for the ethical approval, is going to look at the clinical, biochemical and radiological basis of related post-COVID conditions among the participants of study 4. So our initial observation, like I said, we have already found that from the context of the community at large and the family members, they are also affected by these conditions, and it is important to understand their aspect because we believe they will be playing a major role in the support structure in the coming years, and understand the challenge of the frontline health workers to really how they can cater services to people who comes with various signs and symptoms related to post-COVID conditions. And from study 4, what we have basically found, because we are at the very early phase of analysis, we have seen that at least 20% of our study participants are suffering from respiratory symptoms such as shortness of breath. And it is important to understand that 76% of them had no breathing problem before catching COVID-19, and roughly a little more than 50% had this recurrence of symptoms within a month. We have also found that roughly about 43% of our participants had difficulties in performing daily activities, and about 67-8% of them still have these activities. We've also seen that a lot of, 6% of our participants were completely unable to perform their daily activities which they used to do before catching COVID. 38% of participants experienced palpitation resembling cardiovascular involvement. About 10.4% suffered from swollen ankle, which was developed after a month of hospital release. We've also seen some of the mental health burdens among the participants. Apology for the word depression. These will be depressive symptoms. So we have seen that there are considerable burden of depressive symptoms, anxiety, and stress among patients who were hospitalized with COVID-19-like symptoms. And we've used validated scale called DAS-21, which is a self-reporting tool to document this mental health burden. So based on this, what we think one of the major challenges in NMIC to handle post-COVID condition are, we've categorized them in 4 categories. The clinical challenges, which largely refers to having an appropriate, effective algorithm to be able to manage patient and related training of the health workers and access to proper information for them to continue to update their knowledge so that they can cater services to these patients more effectively. We need to also address various system-related challenges which will enable mobilizing additional resources and fostering collaboration between various policy makers and other stakeholders, ensure a workplace safety for the health workers, as well as sensitive services for welcoming people with post-COVID-19 complications or symptoms. Community needs to be needs to make them more aware so that they are also supportive to people who have post-COVID complications, and to a large extent we need research to understand all of these, how we can and through this research we can foster an effective and more contextualized response plan to be able to handle this major burden that we're expecting. So that's all for me. Thank you very much. And I apologize for being a bit over the time.
Thank you very much, Dr. Tanvir. We're now going into our question and answer session. If you have any questions, please feel free to raise your hands and we can unmute you. Otherwise, you can post your questions in the Q&A chat, and you can address the person you write the name of the person you're addressing the question to, and we'll discuss a few of the questions. A few of the questions have already been answered in the chat, so I'm going to go through some of the questions, or if anyone wants to raise their hand to ask a question, please go ahead. The first question goes to Ms. Stone. One of the questions is an anonymous attendee was interested to see the reference to nutritional depletion as one of the 6 areas. Does this suggest that one might expect to find high levels of long COVID in places with a high incidence of undernutrition, like high levels of, particularly in low middle income communities? And are there any studies showing that this is indeed the case? Ms. Stone?
Yes, thank you for that excellent question. So in this case, the study showed that acute infection actually caused the high levels of undernutrition in specific nutrients. So I believe it was things like vitamin D and zinc and so forth. I imagine that would be compounded by existing malnourishment. So I could see it being worse in low and middle income countries in some cases, but that's completely speculative. I am not aware of any studies showing that that is the case at this point. I believe that the study that is referenced in the slides does point to the nutritional depletion occurring, but that's all.
Thank you, Ms. Stone. Prof. Soriano, you have something to say? Please go ahead.
Yes, I agree with Heather. And if I can add up, COVID-19 and post-COVID-19 condition are 2 new diseases. And actually, every month we know new things about them. But on the risk factors from moving from the acute COVID-19 to post-COVID-19 condition, long COVID, at least we have a number of risk factors. One is gender. It is more common in women. Second, age, particularly in women who are young adults in the ages of 20 to 40 years. And the third factor is those who had 3 or more symptoms during COVID-19. So basically the asymptomatic or the post-symptomatic usually do not end up by having post-COVID-19 condition. The factor of low body mass index undernutrition has been suggested. It has been suggested also some blood types. There is the protective factor of vaccination. But again, for instance, there are many unknowns. For instance, the key influence of variations of concern. We don't know if the overwhelming number of Omicron cases that we are experiencing in this wave will produce more or less COVID-19 compared to the Alpha, the Beta, Gamma, or the Delta. So keep watching.
Thank you very much, Dr. Tanvir. To any of the speakers, would you estimate the cost effective of any preventive strategy versus treatment? Can anyone answer that? Dr. Agustin, do you want to tell us your thoughts on the cost effectiveness of prevention?
Unfortunately, we don't have enough information to answer this question, because to answer this, we need a comparative effectiveness of each strategy and also the cost of this. So unfortunately, we are very early in the research to answer this question. I'm sorry.
Any other thoughts of cost effectiveness, prevention versus treatment strategies? Prof. Soriano, you have a comment?
Very brief. If we know something, is that strategies that wanted to produce natural immunity in the population by infecting and not having the usual hygiene have proved worthless. In the Scandinavian countries, especially Sweden, was aiming for natural immunity, and it has been extremely and extensively proved in Lancet and in other publications that this produced more deaths and this produced more use of health services. So for now on, the only preventive, highly cost-efficient thing we have to avoid long COVID is not to be infected by the SARS-CoV-2 virus.
Thank you very much. We have a question from Dr. Bruce Chirenga from Uganda, who would like to know the panelists' thoughts on why depression seems to be higher in the milder cases. One would think that it should be more in those who have had severe disease.
I think I can take on that for a while because I kind of agree with Dr. Chaponi. It's very early to say this stuff. Any conclusive comment. It's very difficult. However, I'd like to remind that we have used in our data a scale called DAS21, which was self-reported tool. So when we asked our participants about their depressive symptoms and all these things, we can't really actually conclusively say that they had depression. That's why I apologize. That was a wrong word for me to use. It should have been depressive symptoms. So that makes it more accurate for our data set. So yeah, maybe that's I'm not sure whether that answers your question.
We have another question. When donating medicines to LMIC, which therapeutic areas should we focus on to treat long COVID? And I would add to that, which particular drugs should we focus on? I'll focus that question. We'll go to Prof. Juan. I think your experience from Argentina.
In which drug we need to focus, we need to know which is the burden, the real burden of long COVID. So some studies have highlighted, for example, the burden in terms of cardiovascular disease, that is the most important burden in general. But if long COVID affects also this condition, for example, cardiovascular condition, we need we can expect to face a pandemic of cardiovascular diseases. So we should recommend to have a very good register and to focus in this main factor. Also the respiratory conditions, and of course we cannot, as Ahmed said, we cannot miss about our psychological condition, psychiatric condition, and the impact on quality of life.
Thank you. What lessons are we learning from past disease outbreaks? Can clinicians in low resource settings build on, what lessons can they build on in preparation for post-COVID management or post-COVID strategies? Do we have any lessons learned from other diseases from the past?
May I take
Dr.
on it?
Sanger.
Yes, yes, thank you. I mean, then again, I mean, this is a very hypothetical question. We are very at a very early stage, but my take on this would be based on a resident from a low and middle income country and experience in Bangladesh. I think what we have largely failed in overall low and middle income country is to use our excellent primary healthcare setups. We were more focused on facilities and managing cases, but this is long COVID. We are talking about a large part of which we are expecting it to be rehabilitation, follow-up, which longer term, and supporting patient from different angles. So I think it is very important that we continue to focus on training our primary healthcare set layers and bring them on board with proper training, access to information, various logistical supports, and yeah, that would be my quick response.
Thank you. Heather, do you have a response, an answer? You had your hand up.
Oh, that was actually to a previous question about the donation of drugs and which drugs to consider for repurposing. I think it's unfortunately premature to make any decisions about it. There are no drugs that have been demonstrated to be effective at treating long COVID symptoms. There are just beginning to be a few clinical trials that are looking at particular drugs, mostly in the areas that I've specified. A lot of them are looking at dyspnea as a particular symptom or other pulmonary symptoms, probably because that's relatively easy to evaluate as an outcome compared to things like brain fog and fatigue, which are extremely debilitating but difficult to measure accurately in clinical trials. There are anecdotal reports, and I mean really anecdotal, of the H1, H2 antagonists, having some positive impact in some patients, particularly with fatigue and headaches, and with the anticoagulants in some patients with dyspnea. But it's so early that I think it would be ill-advised to donate medicines with that particular purpose in mind, because we just don't know that any of the drugs are effective, and would really encourage the group to think about, how can we study these drugs in ways that will get us to answers quickly, so that then efforts can be made both within the countries themselves, as well as any donations and so forth that will be more appropriate and will be helpful to the patients who really need these treatments.
Thank you, Heather. Unfortunately, we don't have enough time to answer all the questions, but I encourage the panelists to put answers in the chat. I want to introduce our last speaker, who is Professor Richard Maud. He is the head of epidemiology in Mahidol University in Bangkok. and he is a professor at he's a professor of tropical medicine at the Center for Tropical Medicine and Global Health at University of Oxford. His research combines clinical studies, descriptive epidemiology, and mathematical modeling in South and Southeast in Asia. And in particular, he's been focusing on COVID-19 environmental health, and he's a co-chair of this working group, the Clinical Epidemiology Working Group that organized this. So welcome to our final speaker, Professor Maud.
Thanks, Christine. Just to say, what an excellent set of talks and a great lively discussion responding to those questions. I'll just do a very quick recap of the major points as I see them. So we started with an introduction to the CRC and the working group from Juan Carlos, and highlighted some key gaps in our understanding, particularly in LMICs, about post-COVID condition. Our keynote speaker, Juan Soriano, talked about the clinical case definition from the Delphi survey and highlighted the importance of having a clear and agreed definition, so important. We heard about country experience from Argentina, from Agustin Ciapponi, and particularly the lack of local recommendations and guidelines for the condition, as well as the need for more research to guide management in LMICs. We heard from Heather Stone about potential repurposed drugs for treatments for long COVID. She talked about some of the pathophysiological mechanisms and potential treatments that could target these, and the potential benefits of off-the-shelf treatments, although we of course need trials to test how efficacious they are against the syndrome, the post-COVID condition. And then finally, we heard about challenges for patient care in LMICs and some of the research by the Sahida Foundation of Bangladesh from Tanvir Ahmed, and their 5 studies covering context, signs and symptoms, and physical and mental health burden. So a great set of talks, clearly a lot that we know, but a lot more that we need to find out about post-COVID condition. So you can apply to join the Clinical Research Coalition and also the Clinical Epidemiology Working Group. So hopefully there's a slide going to appear. There's some links in the chat. So you can either use the QR code or that bit.ly link. And then there's a form that'll take you to if you're interested to apply to join. We also very much welcome your feedback on today's webinar. And there's a feedback survey, which should pop up. Hopefully that'll work in a sec. And just on behalf of the Clinical Epidemiology Working Group, I'd very much like to thank all the speakers and the moderators, as well as the team who helped behind the scenes to set up and run this webinar so smoothly. And a very big thank you to everyone who's joined, giving your valuable time to participate and ask questions. And on that note, I'd like to wish everyone a good morning, afternoon, and evening, and hereby declare this webinar closed. Thank you, everyone.